Stroke is a focal neurological deficit, which is of no other origin but cardiovascular in origin.
Depression is the leading cause of disability. Depression on its own is a persistent feeling of sadness, persistent feeling of hopelessness.
Hello viewers, welcome to this week's episode on Health Watch on Advent Cable Network Nigeria. I am Angela Mwense. Colorectal cancer is fast becoming a major public concern in Nigeria and in Africa in general. It is now the most common gastrointestinal cancer in Nigeria. According to a 2019 article titled Colorectal Cancer in Nigeria, Changing Trends and Clinical Phenotypes, published in the Journal of Cancer Science and Therapy, it reported that in the 1960s, colorectal cancer was the 10th relatively frequent cancer in Nigeria for both male and female. This simply means that in the 1960s, we had very low colorectal cancer cases in Nigeria. However, by 2018, the relative frequency of colorectal cancer had increased to 5.8% and had climbed to the 4th position of all cancer frequencies amongst men. Well, amongst men, it is the 2nd most common cancer, with prostate cancer as the commonest, and the 3rd commonest cancer amongst women after breast and cervical cancer. This incidence is projected to increase by 70% by 2030. This is just about 10 years from today. What we are certain of is that this will have significant implication for Nigeria's slow-growing cancer care system. A couple of episodes ago, we had a discussion on colorectal cancer, but today we shall have a broader view. We shall dwell on prevention and screening. On the program today, I have two guests. One of them is here with me in the studio, and he is Dr. Augustine Uwanho. He is the Chief Consultant Gastroenterologist and Hepatologist at the University of Abuja Teaching Hospital. You're welcome to the program, sir.
Thank you very much,
It's good to
Angela.
have you.
Thank you.
Thank you so much for coming.
Yeah.
And my second guest is joining us from the United States via Zoom, and he's Bishop Augustine Unwaibe. He is an attending physician in the United States. Well, you can send in your questions, adverts, placements, or inquiry on how to sponsor this program on the contact showing on your screen. Thank you so much for joining us today.
Thank you,
Angela.
Angela.
So much. Now, colorectal cancer we're talking about. I know we've had one before. We had, just a general discussion on colorectal cancer. But today, before I even, we talk about the increase, we see that in the 60s, we didn't have too many cases. But today, the cases have gone so much that by 2030, they're telling us that we'll have 70% increase. That is a lot. But before we talk about why we are having that problem, let's discuss what colorectal cancer is. We hear cancer, but this one seems to be in a different place than from what we hear all the time. So what exactly is colorectal cancer? Where is it situated?
All right. Thank you again, Angela, for having me in this program. Colorectal cancers, refer to cancers that arise from the part of the gastrointestinal system, the lower bowel, the large bowel rather, the large bowel, which means the colon and the rectum. Okay. The gastrointestinal system actually starts from the mouth. And then you have the esophagus, which is the tube between the mouth and the stomach. And then you have the small intestine. So colorectal cancer is a cancer of the large bowel, which is the large intestine, the colon, and then the rectum. The rectum is the part of the intestine that is just before the anus. So cancers that arise from this region, they are called colorectal cancers. And what are cancers? Cancer is actually abnormal growth. Normally, the feature of every living thing is growth, and the intestine are part of our bodies that, also experience this growth because you have constant turnover of cells, but occasionally you have abnormal growth and they lead to swellings. And these swellings, they grow abnormally and then they cause harm to the body, and that is what, are called cancers, So they grow from based on various, reasons which we will probably talk about in this program that cause those things to come up. And at times when they come up, you may not even know something is there, except there is an active effort to look out for them. And when they are discovered, usually in their early stages, they can be cured. But when they are discovered late, that is when the problem, that's where the problem is, because oftentimes this cancer, they don't stay where they grow to a certain extent and they begin to spread, what we call metastasis.
Okay.
They go beyond where they started from and then it becomes very difficult to manage.
So the cancer is around where you have close to the anus, you'd say, somewhere around there, not too far from the anus, I would assume.
Yes, that is the picture of the gastrointestinal system. And this is the anus. That's the final part of the gastrointestinal system. So if you trace it up, just proximal, that is before it, is the rectum. That's where fecal matter is usually stored before it is expelled. Then the next is the sigmoid colon, which is like an S-shaped part of the colon. And then you now have a straight part of the colon called the descending colon.
Okay.
And then you have another part that is across, is called transverse colon. Then you have another one that is down, it's called the ascending colon. It ends in this part called the cecum, which is the final part of the large bowel or the large intestine. And on that part you have an appendage, which we are familiar with. Many people are familiar, called the appendix. So at times it gets inflamed and then it can cause some problem. Connecting to this large intestine is the small intestine through the part called the terminal ileum. So the small intestine also has different segments. The end part of the smallest intestine is called the terminal ileum, and that connects. So food gets into the system through the stomach, get digested, get absorbed in the small intestine, then the extra, the waste, gets into the large intestine, and then it goes through the large intestine, gets concentrated, more water is removed, and eventually it's expelled through the anus. Yes.
Oh, that's a good description of what. But later we'll be talking about when the cells start growing, where you have the unusual growth. What?
Actually, it can grow cancers can develop from anywhere along this tract. Colorectal cancers, most of them actually are in the rectum. But some you can find in any part of the colon. Yes.
Right. Okay. That's a very good pictorial representation of this. It makes it easier to have a view of it. In the 60s, we didn't have it. And this is becoming common with almost every other thing you hear about. So what are we doing as a people that is wrong, that is causing this increase?
Right. I think that's a very valid question because, majorly what I can say is that lifestyle changes. When you look at, in those days, the lifestyle was, very, easy. I mean, people go to farm, they walk long distances, people eat freshly made food and all that. And but now we have more of sedentary living. We have people eating a lot of processed meats, red meats. These are some factors that have been found to be implicated in colorectal cancer. There are actually several things that are implicated. It's a combination of factors. You cannot just say this one thing is what caused, is what's responsible. It's a conglomerate of factors, and also there is a role for genetics. So some people have a family history, of colorectal cancer, and that means they are predisposed. And it's also been found, that the African American race actually has a higher predisposition to colorectal cancer than other races. But what is key in comparing our present day to the early 60s is the westernization of diet, eating more processed meat, eating more red meat, sedentary lifestyle, and also the increase of other things like obesity. These all contribute, to the increase we are beginning to find in colorectal cancer.
Okay, we're going to take a short break, and when we come back, we'll discuss more colorectal cancer. Please stay with us. Don't go anywhere.
Screening programs aim to identify individuals with cancers at an earlier stage and allow for treatment before growth and spread has occurred. It also allows for detection of precancerous growths, such as polyps, before the cancer is even developed. Several screening techniques for colon cancer have been used. As cancers grow, they may bleed. Small amounts of blood are not necessarily visible within the stool. Testing stool samples for occult blood may indicate the presence of a cancer within the colon. Several trials have shown benefit from the use of this test as a screening tool. This test should be part of a regular exam. However, it will only detect cancers within the reach of the examining finger, cancers of the mid and lower rectum. Modern scopes have had several improvements. They are thinner and more flexible, with better fiber optics, allowing sharper images. In addition, the instruments allow the use of additional devices for a variety of functions, such as snares for polypectomies, forceps for biopsies, and other injection devices. Flexible sigmoidoscopes are 60 centimeters long and are able to detect about 65% of all polyps. Upon the discovery of an adenoma, a colonoscopy is usually required to evaluate the proximal bowel. Case control studies have shown benefit in terms of reduced colon cancer mortality and incidence. However, they only evaluate the distal end of the colon. A colonoscopy is the gold standard in terms of screening. A scope enters the rectum and is extended through the entire colon. This test will identify almost all cancers and most premalignant polyps. It also allows for the removal of smaller growths. This test only has to be repeated every 5 to 10 years if no polyps are present. Virtual colonoscopy is a new technique that uses computed tomographic or magnetic resonance images to produce computer-generated images of the colon. Patients still require bowel prep and have air insufflated into their colons. In experienced hands, this test is as good as a colonoscopy in detecting cancers and larger polyps.
Welcome back, viewers. Before we went on the break, we were discussing colorectal cancer, and my guest is still Dr. Augustine. Thank you very much, sir.
Thank you.
I'm trying to think of symptoms, because what we hear most of the time, people maybe present it late, I don't know, but are there symptoms that people can say, this is what I noticed, then it's time for me to go and do the test or to find out if there's something wrong with me, or is it just it doesn't present any symptom, or what's going on?
Okay. Yeah, thank you. So there are symptoms, but if you wait for symptoms, you would be you won't be doing the right thing, because the symptoms often come late in the day, so it's better what to do to prevent it, because the focus of this discussion is how to prevent colorectal cancer. So we will prefer a situation where the cancers have not even started, so that you nip it at the bud. If you see something that looks like it, you take it out, and then it doesn't come. But if I must answer your question, specifically, yes, you can have what they call change in bowel habit, which means that maybe the person experiences diarrhea today, tomorrow he has constipation and all that, then you may have some people have issues with abdominal cramps, pain. Some may have, blood in their stool. Those are the more alarming symptoms. And then The one that is much more specific that something is seriously wrong is when the person begins to lose weight. But apart from, say, weight loss and the blood in stool, the other symptoms can go for any other abdominal issue that somebody may have, and you may not think it's anything. You may think, oh, it's just what I ate that gave me this thing or the other. So the symptoms initially are actually non-specific, and the ones that are more specific are maybe there's weight loss or blood in stool, but there are other things that can also cause this, So you don't really want to wait for all these symptoms, before someone does what is needful to check, to do a screening, and there are, proper guidelines on how one should be screened to prevent this. And many people that died in those days, you really didn't know what killed them. But now it's possible to find out what is going on and then stop these things from developing. Yes.
I like that. So the long and short of it is you can't wait for the symptoms.
Yes.
Yes. So now we can't wait for the symptoms, because like for everything for cancer, the popular slogan for cancer is early detection to save you, save lives. So now, we can't wait for symptoms. So nobody should say, because my body, everything is okay, my body doesn't mean something is not going wrong somewhere. That's the summary of it. So now, since we cannot wait for this for symptoms, then it's important that we begin to look at prevention. How do we not allow ourselves get to that point? And number two, how frequently, how do we check? How do we know that we're running into trouble? For the women, you go for, if it's cancer of the breast, you go for the breast. They even tell you the easy way to check, if there's any lump in your house. Okay, so let's talk about prevention. Is it prevention first, or we'll talk about let's figure out what to talk about first? But let's talk about prevention.
Yes. So, how to prevent colorectal cancer? It's, before you go into doing medical tests to check, there are things you can do, because when you know the factors, the things that tend to, predispose an individual to colorectal cancer, if you can correct it and you can avoid them, then you are doing the right thing to prevent cancer. For example, there are things you can change. You can't change your age, for example. I mean, your age is your age, and as you're getting older, it's been documented that with older age, people are susceptible to not just colorectal cancers, to almost all cancers with older age. The body is wear and tear and all that. So, so with older age, so you may not be able to do something about that. But you can do something about your diet. You can do something certainly about your diet. You want to avoid eating what we call red meat. What's red meat? Things like beef, at least minimal. It's not as if you may not take it once in a while, but especially when you get to a certain age, once you are 40 years, red meat should be the least in your diet plan. So we talk about beef, we talk about pork, we talk about goat's meat, lamb meat.
Meat.
Oh yes, lamb meat. These are all forms of red meat, and the one we call bush meat, they are all forms of red meat.
Okay.
So these are the things, and then processed meat like bacon and all those things, because they put chemicals to sausages. All those things are all not good. They all predispose one. So that's something certainly people can do. Then exercise is healthy. It helps, and it also helps the bowel. It helps you to have a good bowel when you do exercise yourself. And then of course you want to avoid negative habits like smoking, alcohol. These are all things that also contribute to cancer risk. And then so these are some of the things: living a healthy lifestyle and maintaining a good weight. So all these things, and and there are some other disease conditions that if people have, they can predispose them, like diabetes. So And if some people have diabetes, what they should just do is to have a good control, make sure it is well controlled and taking the medications. So if you do all these things, you've probably taken care of what you can do as a person. And then eating a healthy diet, take more, there's what they call, low calorie diet. These things predispose, but take things that has more fiber, things that has more fiber, grains and all that. It will help the bowel movement and all that.
About the fiber, because there's so much, promotion of fiber, take a lot of fiber and all that. And sometimes they say it acts bulk to feces, or it helps the feces move. Because sometimes I can imagine if you have piece of things that what you bring out when you go to the toilet, and then when you have that line somewhere in your guts, it doesn't look. I can imagine what that damage that can do. So when we talk of fiber, how frequently should we take that? Is it something we take every day?
It should be part of our meal. What do we mean by fiber? It's vegetables, cabbage, those fruits are some of the fruits, and those are the fiber we're talking about, not processed food, not food that you've removed everything and then it's just so once you eat all those things, with a lot of fruits, vegetables, in your diet, and
water,
fruits.
taking water.
Water helps, obviously. Drink a lot of water. Drink, because the more water you drink, the better it is for your system, because the body is about 60 to 70% water. So you need to drink a lot of water. It helps not just the colon, the kidney, the heart, the liver, and everything, digestion and all that. So those are the things you can do to live a healthy life, and then in terms of now screening, to know, because you may be doing everything right, it doesn't mean that you don't still have a risk, because like I said, there are certain things you can't change. You can't change your genetics. If, for example, a member of your family has had colon cancer, it does mean you have a higher risk of it. So you need to check, and then, so if, for example, let me start with that, there is a family history of colon cancer, you need to do a test called colonoscopy as early as age 40. Some would say 10 years before the age at which the relative got the cancer. The youngest relative got the cancer. So if you have a relative that got the cancer at 40, it means you have to do yours at 30. But the general...
you want to take that again? If that's what you just said, if you have a relative who
got a colon cancer at
a particular age.
So you need to do yours at 40, at 10 years before that.
All right.
Yes. So but the general rule, for colon cancer screening used to be that once you are 50 years, you do a colon cancer screening. And I was, discussing with some folk, about how someone came to me, a Canadian, said his doctor told him, because he works here in Nigeria, that once you are 50, go look for a gastroenterologist to do, your colonoscopy. He doesn't have any complaints, but he came to do it. But most of our folks here, they don't even know about it. So that's one of the screening tests you can do, to do, a screening colonoscopy. Now, another point I need to make is that the age 50 years has been reviewed downwards to 45 with, recent, evaluations that have been made, just a few years ago, it's been reviewed downwards. So these are some tests. There are other tests you can do to also screen. They are not very specific. There's what they call the fecal occult blood test, fecal occult blood test. Occult means it's hidden. Fecal is, from the stool. So you take a piece of the stool and they test to see there is blood in it, because someone may actually be passing blood in microscopic amounts that it's not visible in the stool, and then that is also something that if it's positive, it should go further and do a colonoscopy. And then what do you really find when you do a colonoscopy. Colonoscopy is an imaging, test that will make you to see, as in real life, how the colon looks like. And you remember I showed you how so you go through the anus, and then you go all through, and then you can see it. Before you do that, you would have done what they call a bowel preparation. So you clean it up out. It's all clean, and then you look and you can see as if you're watching a screen, and then everything. And occasionally you may find some swellings, which may not be cancerous. They are called polyps. Polyps. And these are precancerous, some of them, not all.
And they could
change and become cancerous. I don't want to go into too many technicalities. There are different types of polyps. But you can see some of them. So when you see these things, you take them out and then you take them for testing. If they are not cancerous, or they are not the type that becomes cancerous, fine. But if they are the type that could have changed, what we call a malignant change to become cancerous, you have cured that person. So it's gone, and so the person will not develop cancer. Or you could see something there that is at an early stage of cancer, and if you take it out endoscopically, also that's the cure. But you would never have known that such a thing was there, because at those points the person has no symptoms. But most of the time what we see is patients who are already having bleeding, rectal bleeding. They have already started having some of the symptoms I described earlier, and then you go and you see a huge mass. And when you see such a mass, you're already dealing with something that is cancerous. And yes, you can still do something but it's damage control you're doing at that time, So, but the whole aim is to detect these things early, and then to avert all the troubles that come with it.
I'm thinking of a lot of things in my mind now, because personally, sometimes I have difficulty. It's been a long time, going to the toilet frequently. I think sometimes I just need extra help. Maybe I'm just thinking, maybe you need more fiber in your diet, to get you to, get that going. But it's not a good thing to have, because that's the end product of everything we eat. You don't want it lurking there and staying there comfortably. It doesn't look like something the body will like to experience around there. All right, I'm just going to call in Dr. Niwe from the United States. Hello, Bishop.
Yeah, let me just say that when you talked about this, let me emphasize the fact that when the commonest presentation of colorectal cancer is no symptom. The commonest symptom is no symptom.
Okay.
All right.
Okay.
What Dr. Wango just said, when you are now symptomatic, that's bad. When colorectal cancer is now presenting with symptoms, then that's bad.
That's bad.
Right. So the commonest presentation would be no symptom. And that's why if we are waiting to start having symptoms before we start screening, then you'll be at the advanced stage. For example, if you already have somebody who is having GI bleed, who is having rectal bleed, most times it's probably that the cancer is already having some hemorrhagic cancer somewhere, right? That's not something you want to deal with. So the emphasis is that, look, screening should be done based on the guidelines that is available, not waiting for symptoms. I think that's something I really want us to keep it. And to bring this home, you might want to ask why Dr. Nibe is so passionate about this colorectal cancer screening. Well, I think it might help to bring this message home that my own father died from colorectal cancer. And talking about the age, the change of the guidelines to 45 years now, I think that's important. And I think for the gastroenterologist, there is a need to really emphasize that. I think 50 is now old.
50 is now old.
45 should be. Yes, it's now old. Because I have a very very close friend of mine who incidentally is just probably 1 year younger than me. I'm 51 now. So he's about 50. And his dad died from colon cancer. So if he had screened probably at 45, we would have caught it earlier. He was diagnosed with colon cancer last year. So you see that if he was waiting for his 50 years colon cancer screening, he's already late. You see? And of course, if you went with the guideline, really, ideally, he should have been screened at 40 or probably 10 years
10
earlier.
years earlier, yes.
10 years. It's interesting that you don't look at us. Doctors, we are not anything better than the general population. We are probably more stubborn than even the general population. We'll talk about the screening, but how many doctors have done their own colonoscopy? You'll be surprised that many have not. So this message, as we are speaking to you, we are speaking to ourselves. Yeah. It's a message for everybody.
Message for everybody, yeah.
Yes, whether you are a bishop or you are an archbishop, it goes across the board.
So God forbid cannot cut it. God forbid cannot do it. Even if you say God forbid, it doesn't cut it.
I'm a man of faith. Yeah. But I can tell you that there are so many people that are binding and losing, and yet we have buried them.
Yeah.
You know. So unfortunately, I think there's a lot of ignorance. You know. In the church, and incidentally, Dr. Wango is a man of faith. He's a redeemed pastor. Yeah. And I've known him from university days. He's a man of faith. I mean, he used to be the head of the prayer band. I mean, this guy can pray. I mean,
so there's one person that should tell us not to do it. It looks like he should be the one, but now he's telling us to go and check.
If there's one man who should be able to bind and lose all the cancers, Dr. Wango is right there. And if he's telling screen, you better go and screen. And of course, I'm an Anglican bishop, so you have a Pentecostal bishop, and then a Pentecostal senior pastor, and an Anglican bishop. You know, bringing a perspective and saying, look, this is something that we need to face head on.
Yeah.
Right. You know?
Right. Thank you very much. I think that will move, so because coming from a bishop, it will move to the bishop and those that need to hear it. Right. We need to start screening. And then we're going to go on a break, and when we come back, we'll be wrapping up the discussion today. So we'll be right back, viewers. Hi, my name is Oluwadamilola Ilipeju, and I'm your host on the program Joshua Generation.
This program promises to be so enriching, wonderful, fun, and interesting.
Youth the say are the leaders of tomorrow. What do you think will happen to the next generation if these youths are not trained for tomorrow?
We are a chosen generation. We've been called for to show His excellence.
A particular set of people that has a demarcation. Never ever think you are a mistake.
We are a chosen generation.
The light shines in the darkness, and the darkness cannot comprehend it. That is a legacy.
Has given me, for I know who.
Joshua and his generation saw the miracle. They walked through the Red Sea.
Whenever you introspect, there are deep desires of the heart that you wish you could do.
Where He says I'm at, I know who I am.
There are lots of distractions for young people around the world right now. If you don't engage them in the church, if you don't support their talent, nature abhors vacuum.
I am believing God that the Lord will move again, once again, in our time and in our generation, and our eyes shall see it.
Welcome back, viewers. Before we went on the break, we're discussing colorectal cancer. My guest is still Dr. Augustine. Thank you so much, sir, for all the information we have gotten today. Now, as a pastor, you know, he has talked about, he's given us your CV. So, what do you say to Christians? There are Christians that you would tell them to go to the hospital. Even some don't even believe in going to the hospital. And I'm really glad you're a man of God. and you're also a doctor, a medical doctor. In fact, not just a medical, a chief consultant. So please, there are a lot of our Christian brothers and sisters watching. What do you tell them?
Okay. Yeah, thank you very much. You know, the Bible says, my people are destroyed for lack of knowledge. The truth is that knowledge is given by God. And ignorance is what leads to a lot of damage and destruction. Okay? And if you listen carefully to some of the things we've said, you discover that from the Bible you will see, you can find a lot of correlations. There's nothing wrong. You know, your faith does not negate you going for a medical check or engaging in a medical therapy. It doesn't. And I'm sufficiently educated both medically and scripturally to know. For example, Hezekiah in the Bible was sick. And, you know, when the prophet came to tell him, you put your house in order, you're going to die. And he prayed. And God told the prophet, go back and tell him he will not die. God also told the prophet to tell him to engage in some medical therapy. He told him, it's there in Isaiah 38, you know, to get some herbs and put on those feet that were hurting. That was what was available then.
At that time, yeah.
But now, by the, you know, abilities that God has given, you know, we now have a lot of facilities available. And why don't you use it to your advantage? It doesn't negate your faith, you know. And and the other thing is, you see, there's the difference between faith and presumption. There are many things people call faith is just presumption. which rides on the foundation of ignorance. You know, just a simple check will tell you how you are doing. A simple check will tell you what is going on. You know, we're discussing colorectal cancers now, but let's talk about blood pressure. You just check your BP, you know what's going on there. Check your blood sugar, you know what's going on. You know, so it's important that people should go for check. And our focus in this colorectal cancer, we don't want anyone to have cancers. And that's why we are asking, do the screening tests. And there are recommendations that have been put there, you know, for everyone. Once you are getting to 50, now it's 45 years, that is their, you know, approved timing for check. Go and do a screening colonoscopy. The other thing I must say is, you may not even know whether you have a first degree relative that has died of this, because they themselves may not have gone to a proper hospital to have a proper diagnosis. So you don't even know if there is someone who may have suffered from this, that you may be related to one way or the other. So do the check and then know what is going on. And if you have symptoms, don't just go to a quack. You know, unfortunately, you see people go to, you know, a drugstore and then they just tell them, this is how I'm feeling, give me medications. And then when they feel better, they feel it's all gone. It's better to seek a proper medical, you know, counsel and evaluation to know what is going on. So that's what I would want to tell my fellow brethren. You know, they shouldn't be averse to medical tests, medical checks, and medical screening.
Thank you very much, sir. Just one question before I call in the bishop for his last words. The cost, is it cost intensive to do a screening, or it's reasonably affordable?
Well,
because sometimes people might say, well, it will cost me a lot to do the screening, and of course the cost is not there.
Yeah, cost is usually an issue. I mean, we know our people, many of them are trying to make ends meet, but you know, when you put it vis-a-vis having the disease, you discover that the cost is not an issue. Colonoscopy is not a test you do every day. You know, it's a test that, depending on the center, you may get it for as low as maybe 80,000 to higher than that, depending on, some may be cheaper, depending on the center who is doing it and all that comes in, and it's not done by everybody. It's done by specialists. It's done by specialists, and if it is normal, you don't need another one until another 10 years.
10 years, okay.
So it's not a test you say you do today, tomorrow. No, if it's normal, you don't need another one until another 10 years. And if you find something that is just at its early stage, dealing with it at that time, you would have saved yourself a great deal. Some people, when they get these colorectal cancers, they have surgery, they have what they call chemotherapy, they have immunotherapy, they have radiotherapy, and this costs millions of naira. And after all that, there is still no assurance that they're going to get back their health. Some of them, the maximum they can live after they've done all that is probably 5 years. Some, if at best, 10 years. So you can imagine all that. So you can't put all that in comparison to doing a test that will either show you that there is something or show you that there is nothing, and then you know that, okay, you are good to go, and then you have another 10 years to check. So it's not comparable.
It's not comparable. So it's important to do the screening, whichever the case. If you have to save, you save to get that done. All right, we just take just the last words from our Bishop Augustine Naibi. Can you hear me, sir?
Angela.
My Lord, okay.
Angela, so...
Your last words,
last, I just want to, of course, re-emphasize why, again, we are taking a war against colon cancer. Angela, Archbishop Kwashi just came back from the United States, right? Right. After an 8-month battle with, and did you know what cancer he had?
I just need cancer, but I didn't know what one exactly.
Okay, well, it was on the press. It was diagnosed with stage 4 colon cancer.
Wow.
Okay. And Dr. Wangu can speak on this, but definitely if that was in Nigeria, it was almost like a death sentence. But miraculously, God helped him with the support of friends in the United States that he has. The average Nigerian would not have that. The average bishop would not even have that. The average archbishop in Nigeria would not have the kind of treatment Archbishop Kwashi got. So what I'm saying is, look, cancers are very expensive to treat. If they break it down and tell you how much it will cost to do complete treatment, you would just say, you know what, let's just go and buy casket and just prepare for burial. It's very expensive to treat cancers. So prevention. A bishop diagnosed with cancer can wipe out the whole money of the whole diocese. Just one bishop. So I think this is something I'm taking very personal. I'm taking to the House of Bishops. I am taking to the House of Clergy, and I'll take it also to the House of Laity. You'll be hearing more about this. I'll be talking a lot about this.
And we'll work out something together even on the program to talk more so that most of our fathers in the Lord can hear about it.
Right, we'll make t-shirts, we'll make face caps.
Thank you
we'll
so
make
much.
everything.
Thank you.
And I'm sure I'll be talking with Archbishop Kwashi, and we'll be working on this.
Yes, on this, yes. Thank you very much. Thank you very much. Thank you so much, Doctor, for coming on the program. Thank you for the wealth of knowledge you've given us today. We really, really appreciate it. For the past couple of minutes, I've been speaking to Dr. Augustine Onwaho, Chief Consultant Gastroenterologist and Hepatologist at the University of Abuja Teaching Hospital. And also joining us from the United States via Zoom was Bishop Dr. Augustine Naibi. He's an attending physician in the United States. Thank you so much for joining us on the program today. Thank you so much, sir. Thank you. And my love to people in the United States. All right, that's all we can take on the program today. I'll see you next week. My name is Angela Mweze. Goodbye.